So this is the case scenario. Are you able to see my screen?
Yes, sir.
Yes,
Yes,
sir.
sir.
Yeah. So this is the way you usually find diabetic ulcer patient with a severe ulcer coming to the hospital. You see some of the skin is gangrenous, dark in color. This toe is almost gone, and you have ulcers, you have edema. So this is how the picture will look like. So I'm just giving you a imaginary case scenario. A 65-year-old male patient with a foul-smelling right foot ulcer, 3 weeks duration, developed ulcer after wearing a new shoe because of shoe bite. Ulcer gradually increased, and there is a moderate pain in the ulcer. Patient is drowsy, tachypneic, and tachycardic. So 3 weeks of this very foul-smelling ulcer. Patient drowsy, tachypneic, tachycardic. What does it indicate?
Decays.
Decay.
Might
The
be in sepsis
possibility of
decay.
decay. Patient is dehydrated, febrile, and the patient is a known DM for 15 years, diagnosed during a master health checkup. The medications we are taking, mostly they are all oral medications, glimepiride, metformin, and Rolvedon. And earlier, before the ulcer started, he had a good glycemic control, and he was checking it by point of care testing using glucometer at home. And random plasma glucose became 340 after ulcer developed in the foot. Okay, so if you try to, Jayabharti mentioned proper glycemic control is important. But once if it is an infected ulcer, however much you increase your dose of insulin, very rarely you will be able to control the sugar to bring it down to less than 200 because until the infected source is removed from the body, there is always a constant stress and catecholamine release will be more, and these will be counter-regulatory hormones, and so patient will not have a good glycemic control. So the main point all of you should understand is if the patient is not in DKA and if the blood sugar is high, you should not cancel the case or postpone the case. You must administer nowadays, as I told you, you have the excellent short-acting drugs with which you can reduce the blood sugar, and we can take up the case. And unless the source of infection is removed, patient will not improve. So we were started on mixed start because this is an earlier slide prepared some 5 years ago by me. So at the time, newer insulins have not become very popularly used in practice. So patients usually had this older insulins only being used. So the random blood sugar was controlled to be brought over to 245, and patient had subsequent history showed that he had a chest pain, which was diagnosed to have stable angina, single vessel disease, so managed conservatively with these things. So evaluation of the cardiac status, especially painless angina, should be inquired. And in your theory paper also, you should highlight and mention about the possibility of a patient having a painless angina and a coronary artery disease. And he had elevated renal parameters and he had a decreased hemorrhage. All the microvascular complications are present in this patient. And patient had pins and needles sensation both with the feet and hands and has reduced sensation. He had altered bowel habit, constipation alternating with diarrhea. He has GERD, he had erectile dysfunction and giddiness when getting up. All these things indicate that the patient is in a state having a diabetic autonomic neuropathy. But his effort tolerance is very good. He is able to walk 3 kilometers comfortably and he is able to climb 2 flights of stairs without shortness of breath. So there is history of weight gain, dry skin and loss, which indicated that he is also a hypothyroid patient, which corrected with Elproxin. And he has a difficulty in extension of neck. So the airway assessment shows he has a restricted neck mobility. Patient had earlier symptoms of hypoglycemia and started on OHA, which is corrected with oral glucose. But there was no history of drowsiness, excessive urination, after the ulcer developed. It indicates that his possibility of DKA now. He uses a footwear while going out. He has not taken any native treatment. This is also a very important point you have to elicit in the history level, both in the practicals and theory exam, because many patients go for native treatment, which may have a bearing on the renal or the cardiac functions. And he had not had any previous surgical treatment. Now coming to the examination, vitals are normal, but puff creatinine positive, which again indicates the difficult airway management. And then you have to go for local examination. In the exam, you have to describe the ulcer also. If it is given as a short case in your practical exam, you will say 16 to 5 ulcer over the ball of the great toe on the right foot. Margin slightly raised, there is a healthy granulation seen in the bed, and a slightly serous discharge with no offensive odor. Initially, it came with a foul smelling ulcer, but probably after the proper antibiotic therapy, now the infection is controlled, so there is no odor. It's painful when pressed around the ulcer, warm to touch. What is the importance of warmth in the skin when you touch the ulcer? Which ulcer will be cold?
Ischemic ulcer will be cold.
If the warmth is there, that means good blood flow is
Good
there.
blood supply.
Ulcer is cold, inflammatory, it is an ischemic ulcer. Okay? So ulcer belongs to Wagner's grade 2, and you must do the monofilament test to find out the sensation towards the third and fifth toe. Ankle jerk, not the deep tendon jerks also you have to mention. Ankle jerk is normal, that indicates motor nerves are not affected. Only purely sensory neuropathy, not a sensory motor neuropathy. And you must mention about the pulsations in the area. Dorsalis tubules and posterior pulsations are normal. And ankle brachial index. This is one of the common questions they will ask you in the exam if you have a diabetic ulcer foot. So, anybody knows what is the ankle brachial index?
So to rule out peripheral vascular diseases.
How do you check it? How do you do the ankle brachial indexation? You must check the blood pressure in the arm as well as in the leg. Yeah, systolic blood pressure in the arm and systolic blood pressure in the leg should be equal. That means one means both are 120, 120 means 1. If the systolic blood pressure in the arm is more and the leg is less, that means less blood flow is going. So the leg will be, so it is leg by ankle, arm. So ankle blood pressure should be equal to brachial blood pressure. Then you get an index value of 1. If the ankle systolic blood pressure is less and brachial blood pressure is normal, then it will be less than 1, which indicates a reduced blood flow. Okay, so this is one of the important things to identify whether it is already a ischemic limb or not. And sensation over the rest of the foot normal, no motor weakness of the foot. And treatment options are based on the Wagner's classification. Grade 1 is a superficial ulcer. Grade 2, ulcer extending to ligament, joint, and fascia, but no abscess or osteomyelitis. Grade 3, deep ulcer with an abscess and or osteomyelitis. And grade 4 is gangrene. Straight away, there is a gangrenous stage in the fourth foot. And grade 5 is extensive gangrene going beyond the area of the ulceration. So grade 1 to grade 3, you can do some debridement and it may be allowed to heal naturally, or you can put a graft, or you can do a flap cover. Whereas if it is grade 4 and 5, invariably they will all result in amputation. There is no point in wasting time to save that limb. So this is the classification. You can see at 0 there is no ulcer, but it's a high risk foot. And in grade 1 there is a superficial ulcer following only the skin. And grade 2 has become deeper, going up to the ligaments and the fascia. and grade 3 going down below the fascia, go up to the bone, and grade 4 is local gangrene, and grade 5 is extensive gangrene going up to the bone. So there is another University of Texas system of classification, which was just for the knowledge. You don't have to write all these things in your exam. Just remember that there's another way which will describe the grade and depth, and to see how deep is the wound and what are all the things that you can do again with infection, without infection. These are the classifications A, B, C, D, grade 1 to 3. So just for the knowledge I have put it in. So next comes the investigation. Apart from routine investigations, you must check for the fasting postprandial HbA1c, see the glycemic control, EKG for any infectious changes, CXR for cardiac size and apical tuberculosis, echo for LV function and region wall motor, Doppler study, and wound swab and culture, ultrasound to rule out any medical disease, and optimization before surgery, wound infection control with suitable antibiotic based on culture and sensitivity. Glycemic control, you have to switch over to short-acting insulin if the patient is on long-acting insulin so that you can have a better control. Stabilization of comorbid conditions, ketone estimation and correction if needed. This is the important thing which you have to do routinely in your pre-anesthetic, pre-surgical optimization. Uric acid estimation needed and treatment to rule out further renal damage. Now, regional anesthesia is the most opted anesthesia technique by most of the anesthetists. The advantages are, as we said, less fluctuation, and less stress and less sugar fluctuation level, and easy to identify hypoglycemia because the patient remains conscious. And you can add an additive to give prolonged post-op analgesia also. And because you don't have to manipulate the airway, difficult intubation or aspiration risk is not there. The disadvantages are hypotension with SAD, especially with autonomic nervous dysfunction, will be very severe. And the duration of anesthesia is limited with single shot. So if the surgeon wants to have a longer duration of surgery, then it may not be suitable. And epidural is contraindicated because of the infection. It can result in epidural abscess. And hypothermia and shivering can happen in these patients when they undergo regional technique. So the next alternative is GA, which is for especially long duration surgery like flap cover or microvascular procedures are also nowadays done for management to cover the wound and preserve the foot because going into amputation. So if the patient has preference of autonomic established DAN, then you have to go only for GA. And patient refusal for RA is also another indication for GA. And if the wound is severely infected, in that case also it is better to go for GA. And other regional techniques are, one is SAB, which is the easiest and most prevalently done. Second is combined spinal epidural, continuous epidural if the infection has been well under control. Then nerve blocks, ankle block for dry gangrene without infection, and intravenous regional anesthesia. These are all the RA techniques which are available. And what are the instructions you have to give for elective procedure? Free of starvation, angiolysis, anti-aspiration prophylaxis, stop any antiplatelets if the patient is on, stop IAC because they are taking for blood pressure, check CBG before shifting the patient to OP and inform the value. Now, what are the instructions with regard to anti-diabetic drugs? That also is a commonly asked thing in the practical exam. The patient is a well-controlled patient on oral hypoglycemic agents, and if the surgery is in the morning, skip only the morning dose of the tablets. Because the patient is in NPO, you don't have to give the morning dose of tablet. Check the blood sugar before the patient comes to the OP. If the patient's blood sugar is less than 100, then give 5% dose with normal saline. If it is more than 200, only normal saline to be started. And resume oral when permitted and give the OHA if taking normal diet. So that is the instruction for a patient with a good control with a very superficial ulcer coming for management. Now, if the patient is well controlled over with OHA, but surgery is posted in the afternoon or it's late in the evening, some nursing homes do it. The surgeons convenience, they post the patient. Ideally, all diabetic patients are operated first in the list in the morning, but it doesn't happen all the time. So if they are going to be operated in the evening or late in the afternoon, allow normal breakfast, skip metformin and omnibus, give the other tablet, half the dose of the glimepiride. That sulfonylureas you can give half the dose instead of the regular full dose. And rest of the inspections as per the patient A, that is NPO, the anxiolysis of anti-aspiration prophylaxis, all this will go. And the third category of patient who is on OHA plus insulin, surgery in the morning. Then omit all the OHA, check fasting blood sugar, 100 to 200 is the value, no insulin. But if it is less than 100, again start 5% resveratrol because we are more worried about hypoglycemia than hyperglycemia, and the dosage will be 50 ml per hour. And if the blood sugar is more than 200, divide the value by 150 and then use actrapid or plain insulin, short acting insulin subcutaneously to control that sugar. Now the fourth category, patient is on OHA and insulin, but surgery is in the evening. Allow normal breakfast, omit all oral hypoglycemic agents, half the usual dose of the insulin that he has been taking regularly to be given along with the breakfast in the morning. And start NPO, but watch out for symptoms of hypoglycemia. Start 5% dextrose infusion if CBG is less than 100. And instructions for the 4 groups of patients receiving oral intake will be allowed early in the post-op. So this is the criteria for patients who have a superficial ulcer and the procedure done, where we can resume oral intake soon after the surgery in the post-op period. Now, patients awaiting cardiac, neuro, and pregnant patients, they require tight control of their blood sugar. So this is not relevant here unless the patient has a comorbidity like this. And this is achieved by intravenous infusion of short-acting insulin. For that, there are 2 regimens which are popular. One is called the fixed glucose infusion by Albert E. Thomas. The second is the variable infusion by Watts et al. So, as an alternate to these 2 regimes, there is a third regime called Velour regimen, claims advantage of being less expensive because it doesn't require any expensive gadgets like infusion pump or filling pump, all that. And this is a picture of how the radial forearm flap for reconstruction is done. And so for the benefit of those who have not seen a procedure like this, the part of the skin is the thickness tissue along with the radial artery is taken. This is the flap that they have harvested with the vascular pedicle, and then the wound is debrided and the flap is fixed here. We can see a nice cover, and this sort of faciocutaneous flap with a vascular anastomosis will give a better healing as well as will protect the foot from going in for further infection and prevent any need for amputation also. To be more conservative, that is how this is being done. So next I will try to just share with you PPT.